A very warm welcome to this ETSC PIN webinar on serious injuries. My name is Ellen Townsend and I'm the Policy Manager here at ETSC. It's great to see so many of you online and here with us this morning. The event is going to be recorded. We'll make the recording available in the next few days together with the presentations. If you have any questions, you can use the Q&A box at the bottom of your screen. And we'll have a Q&A session at the end of each of the two panels. Our PIN programme is supported by the German Road Safety Council, the Norwegian Public Roads Administration, and CITA, the International Motor Vehicle Inspection Committee, Fondation Mapfre, and last but not least, Toyota Motor Europe. So we've got an exciting lineup of speakers for you today on the topic of serious injuries, and we thought it would be nice just to introduce them to you before we get started. So my colleague Jenny Carson is going to give an overview of ETSC's latest report on injuries. She'll be covering what the latest data show along with our recommendations. Next up, we have Peter Witten from the European Commission. Warm welcome to you. He'll be giving us an overview on the serious injury target and the KPIs aiming at reducing the number of serious injuries in Europe. Then we move to some country experiences in collection of serious injuries. We will have Mary Skiving of the Swedish Transport Agency, who'll be sharing with us the Swedish approach on police and hospital data. Then we'll have Stefania Castello from the Road Safety Authority presenting an Irish study digging into the important topic of underreporting of serious injuries. After Stefania, we go up to Finland, where we'll have a presentation from Nora Araksinen from the Finnish Transport Infrastructure Agency that will present the Finnish experience in converting ICD to AIS codes. Last of this first panel will be Céline Vernet from the Gustave Eiffel University presenting the French experience of estimating serious injuries based on the Rhône registry. Then we'll have a break. We'll be needing a break after all of that input. Then we have another panel that will look into the countermeasures, so what we can actually do in order to reduce the number of serious injuries in Europe. First, we'll have our colleague Veronika Valentova from the CDB presenting research findings on forgiving road design. Then we'll have Martin Winkelpower from the KFV showing us protective equipment that could prevent serious injuries among powered two-wheeler riders. After that, we have Astrid Lindner from the VTI presenting the differences in risk between males and females and how those differences could be tackled. And lastly, but not leastly, we know that many serious injuries happen amongst the cyclists, and we'll have Masha Odik from SWOV presenting the Dutch experience of infrastructure changes to reduce single bicycle crashes. So after that big round of introductions, let's get on with it. So I'd like to give the floor to Jenny, the PIN Programme Manager, who will tell us about ETSC's latest findings and recommendations for serious injuries. Over to you, Jenny.
Thank you very much. So, I'm going to talk to you today a bit about the findings of a report, PIN report that we published at the beginning of this year. So firstly, just a bit about the PIN programme for those of you who are new to it. PIN stands for the Road Safety Performance Index Programme, and it's really about benchmarking the road safety performance of 32 countries that you can see there on the map. So all the EU member states, the UK, Norway, Israel, Switzerland, and the Republic of Serbia. And it's about benchmarking, so it's looking at performance, but it's also about inspiring through the PIN Prize and sharing good practices, which is what today is all about. So what can we say and what did we find in our PIN report from March of this year? So you can see here progress over the decade 2013 to 2023, and comparing the sort of progress in reducing, let's hope, serious injuries with road deaths and also slight injuries. So you can see there that serious injuries are reducing more slowly than road deaths, but slight injuries are reducing even more slowly. The trajectory is fairly similar, big dip in 2020, obviously, and rising back up again in the last few years. So you can see similar sort of data here, but across the 32 countries that we collect data for here. So this is the average annual change in serious injuries over the decade 2013 to 2023. And comparing it with those empty boxes, see-through boxes, are road deaths. So you can see whether serious injuries are reducing more slowly or even increasing more quickly than road deaths in each of the countries. And it's a fairly mixed picture. So what do we know about the road users? Who is it that is seriously injured on our roads? And we can see here in the pie chart that 57% of those seriously injured are vulnerable road users, what we would term vulnerable road users. And in fact, the largest portion of that pie, 25%, are cyclists. And that's fairly significant piece of data, of knowledge that we saw. Here you can see that same data in terms of the road users that are seriously injured, again across the 32 PIN countries that we gather data from, and you can see a very mixed picture. It's very clear, let's say, where there are very sort of strong cycling nations. So you can see in Sweden, the Netherlands, Denmark, their purple piece of the bar, the cyclists, is really quite large. It doesn't mean that they're particularly dangerous for cyclists. It just means that we know that there are a lot of cyclists in those countries. Similar for some countries where we know that power two-wheeler riders, there are a lot of them, and so they appear as well quite forcefully in the statistics. Here we can look at the data of the road users, so who is seriously injured, the different proportions compared to what we know about road deaths. And I think one of the most significant bits of information here is looking at those purple and green bits of the bar. So again, we're focusing here on cyclists and pedestrians, our most vulnerable road users. And there's a big difference there in the number of cyclists that are seriously injured versus those that are killed. So we can really see here that cyclists tend to be seriously injured. Pedestrians, on the other hand, are more often killed. So moving on from the road users, we also looked at the age and the gender of those seriously injured. And one of the most significant things that we found was relating to the youngest, our sort of youngest people, 10 to 19-year-olds. And while they represent 11% of those seriously injured, that's twice the proportion that we see in road deaths. So serious injuries is a really important element, sort of, really affecting those that age group much more than in road deaths. We also looked at the gender, and we found that 66% of those seriously injured are male and 34% are female. And that's significant if you compare it to those proportions relating to road deaths, where a far higher proportion of people killed on our roads are men rather than the women. So women really are being seriously injured on our roads, and that's something significant. And I know that Astrid's going to talk more about that later. We can also see how serious injuries amongst the different age groups have changed over the last decade. Again, the dotted line is 2013, the thick line is 2023. And we can see similar sort of trajectories that we see in road deaths as well, that there's been a big drop in the very youngest people being seriously injured on our roads, and then a rise amongst the sort of later 50-year-olds, which we found in road deaths as well. So I've spoken about serious injuries, but actually a big part of our report was looking at what is a serious injury. And although we have benchmarked in our report, we know that the definition of serious injuries does vary across the 32 countries. And we found that 14 PIN countries have a similar definition of spending at least one night in hospital as an inpatient. But there are different variations, and we know that it's difficult therefore to compare. We do have an EU definition obviously as well, with a target which ETSC really welcomes, but it is taking some time to get the member states to gather that data. We don't have as long a trend as we have with national definitions, so for the majority of the figures and charts in our report, we tend to use the national definition. So it's good to bear that in mind because it varies. And we do include every definition at the end of the report. But as well as having a definition, the other side of it is who is determining whether an injury is serious. And at the moment, serious injury data is mostly gathered by the police, and rightly so. It's a very important source of data. But when it comes to serious injuries, it's important also to include data from hospitals, which is what obviously the MIS 3+, the EU definition, does. And we gathered data in our report. You can see a small chart there about whether it's mandatory for hospitals to report or to share their data. And you can see it's a mixed picture. So this is the MIS 3+, the EU definition, which is linked to the target of reducing serious injuries as well. And you can see there the importance of, in some way or another, including hospital data within the, to give a good overall picture. Another element to serious injury data is obviously levels of underreporting, and we're going to hear a lot about that after I've spoken. And we include a lot of examples, a lot of research into these, what is the actual level of underreporting. I mentioned before that the police is a big source of the data on serious injuries, and very important, but there are a lot of serious injuries happening on our roads where perhaps the police are not involved. And we find, particularly, let's say, for single vehicle collisions, people falling on the road can also, it's not part of the definition of a serious injury on the road, but things happen where the police perhaps are not called, perhaps an ambulance is called, but not the police. So we know that particularly for vulnerable road users, pedestrian cyclists, also motorcyclists, the police are not often there, so that data on those serious injuries lies more with our hospitals. National legislation can help. We have some examples there of Germany. Police have to attend all the collisions. Perhaps insurance compensation can only be claimed if there's a report by the police. These things can help to incorporate the data into the police, the police data source. But we're going to hear a bit more about that, so I'll leave that to the experts. So what can we do to reduce serious injuries? There's a lot of it is similar to what we might see to try and reduce road deaths on our roads. We know speed is a particularly important factor in many crashes. I've put a 30 sign up here, perhaps given the focus on vulnerable road users, pedestrians, cyclists, 30-kilometre zones in urban areas would be particularly beneficial to those road users as well, in terms of reducing their serious injuries. Also thinking of those people building safe infrastructure, separated cycle paths, but also in rural areas. I think perhaps Veronica will talk about this, making sure that rural roads where we have single vehicle collisions, vehicles coming off the road, that those roads are built safely as well. There's a lot in our report about pedestrian falls. I mentioned they're not part of the definition of a road death in most countries. I think it might be different in Sweden, but they are really significant. And more pedestrians, I think, are injured in single sort of falls than they are in collisions with vehicles, and the same for bicycles. So we really need to protect those. Martin's going to talk about how we can protect power two-wheeler riders, e-scooters, relatively new vehicle. We need to protect them with infrastructure, speed as well. Enforcement obviously plays a big role. I've put here the seatbelt infographic that we have from our enforcement flash. Wearing a seatbelt obviously protects significantly against serious injuries, but speed enforcement is also going to be very important. Can't talk about serious injuries without talking about post-crash response. Anything that makes the time from a crash to going to hospital or response quicker is going to affect the rate of injury to a person. So things like initiatives like emergency corridors, and we gather data about the countries that have those as well in our report. So we have many recommendations in our PIN report that you can find online. I'll give you the link at the end. But obviously trying to improve the collection of your serious injury by linking those different data sources, the police and the hospitals, will give you obviously a better picture of the serious injury situation in your country. Targets for reducing serious injuries. We have the EU target, obviously, which is welcome. I mentioned reducing speed for in urban areas to 30, and developing safe infrastructure, particularly for vulnerable road users, but obviously, of course, on our rural roads as well. Thanks for listening. You can find the report at the link here on the slide.
Brilliant. Thank you very much, Jenny. So yes, we very much encourage you to read the report, but you'll find out a lot more about it because we've invited the speakers who've contributed from their countries to come and present today. But before we do that, I'd like to introduce Peter Witten, Policy Officer at the European Commission, DG Move. Peter works on the CARE database and is always of great support to ETSC when we're collecting our data. So thanks again profusely for that. Now, we know that the EU target for serious injuries is relatively new. About 10 years ago, ETSC was working really, really hard, pushing to have it adopted. It's the first time we have it in an EU road safety strategy up to 2030. But it's challenging. So we look forward to hearing from you, Peter, the challenges and the work behind this ambitious objective and how it could be achieved. Over to you, Peter.
Okay, thank you and good morning to everyone. Just going to share my presentation. You see my screen okay?
Yeah, if you just go into presentation mode, please.
I'm actually in presentation mode.
Maybe it just takes a moment.
Or I have the full screen.
we'll just wait another moment. Otherwise, I ask my colleague Maria to share from her side.
Just see if I'll just try it once more.
Okay, thanks.
No,
No, okay. Should we do the sharing via ETSC, please, Maria?
I don't know whether Maria has my latest.
Well then it's fine. We can
Good.
see them. Just talk to
Okay.
them. It's just a little bit smaller, but
Yeah. Okay.
it's
Apologies for that.
the message that's more important. Thanks,
Yeah.
Peter.
Okay, thank you. So just briefly, as Ellen just said there, the 2030 reduction target, 50% was extended to serious injuries for the first time for this decade. And we're trying our best to be able to measure that. As Jenny said, there are the two sources of data, are the police data in care and then the MIS 3+. So the MIS 3+ was actually, there was a commitment by transport ministers in 2017 and to collect data according to the MIS 3+ scale. We've been working on that for the last 10 years, and we feel that this provides the most accurate data, although care is also useful because it provides breakdowns, for example, including location. We have a current state of play is that there are 24 of the 27 member states report seriously injured in care. As Jenny said, there are differences in the definitions, which are clear when you look at the ratio between fatalities and serious injuries. And we have just over half of the member states reporting according to MIS 3+ annually.
Sorry,
So on
Peter,
average,
sorry to interrupt. Could you try to go to the next slide? Because for the moment, we've just got the title one.
sorry. Okay,
That's
so you
fine.
didn't see this because I see it on my screen.
Peter, do you have two screens? Because maybe you can swap between the screen you
No,
see and the screen.
I just have
No?
one screen.
Oh, that's very strange.
Okay, now we're on
Oh,
the
now we
second
see.
one. That's good.
You're on the second one. Okay,
Yeah.
so now that, well, I already gone through the second one, so
Okay.
I'll
Yeah.
move to the third. Yeah.
Super. Thanks.
Okay, so on average, then there are around 5 MIS 3+ injuries for every road fatality, and this equates to approximately 100,000 serious injuries in the EU. But of course we don't have a lot of data from all the countries on MIS 3+, so we also have to use some data on the police. It suggests a different ratio of around 8:1, and we have countries such as Germany, Austria, and the Netherlands reporting nearly 20:1. So it's clear that there are definitional issues there. We published data as a facts and figures report as part of the observatory. So that's using the same basis as Jenny has used for the PIN report. So MIS 3+ data collection requires a collaboration between the Transport and Interior Ministries and the Health Ministries. We've tried to help by working with AAAM in America, because they created the AIS scale to classify and describe the severity of injuries. And we also procured from them a conversion table so we can map the ICD, the International Classification of Diseases codes, to the AIS codes. And this table is available for all EU and EFTA member states. And we also then, with AAAM, had a training program for member states, and there's a lot of material that's publicly accessible on the website. So for countries who are thinking of using MIS, we'd recommend that you look at that. And it also helped other countries who had difficulties with transcoding improve the quality of the data. The three methods for collecting C++, as Jenny has outlined, so I won't repeat all that. The one thing I would say is that, again, those countries who don't have MIS3+, it's worth looking at other examples where correction coefficients have been carried out. So that's quite a cost-effective approach. If you sample a small number of hospitals, you can then apply a correction coefficient to the police data. And the other point I'd just like to make here, new adopters, again, sort of countries who are embarking on MIS3+, they might actually consider direct MIS coding if they're creating the system from scratch, so they could do direct MIS coding rather than transcode from the ICD. So the benefits of comparing the data, again, as we've already seen, and we'll hear other examples from countries. The road user categories, by looking at analysing that data, it shows underreporting of certain groups in the police data, particularly cyclists and e-scooters. We feel again that MIS3+ provides a more accurate and comprehensive picture, and we then, when we're collecting MIS3+ now, we encourage countries to provide also some breakdowns by age, gender, and vehicle type to try and make the MIS data a richer source. I just threw in a slide here just before I conclude on EU-funded research in Horizon Europe. So there was a call for, the topic was new ways of reducing serious injuries and the long-term consequences of road crashes. And there are two ongoing projects, 4 years each. And they're trying to address the complexities of the long-term consequences caused by road traffic crashes. So they'll be using new data and some virtual testing in human body models. So that's worth keeping an eye on. So in conclusion, we're trying to monitor progress towards the 50% target. We're obliged at present, because of missing data, to use both sources, so both CARE and MIS3+. We've tried to provide training on MIS3+ and funding, as I said, from Horizon Europe to look more closely at the issue. We would consider other training if we think that will help countries who haven't embarked on the MIS3+. It goes without saying that cooperation with the health ministries is key, and we're encouraging then further adoption and refinement of the reporting across the EU. Thank you.
Super. Thank you very much, Peter, for a very interesting presentation. So there are some avenues there to explore, especially for the new adopters, some training to access, and then also some very interesting Horizon projects in the area, which hopefully will also bring some findings that we'll be able to apply. You've presented the European framework and related challenges. It certainly is a challenge. And I'm wondering if that has provoked any questions in the Q&A box. So there will be the chance to pose your questions to Peter at the end of this first panel. So please do send us some questions. So next up, I'm very pleased to welcome Marie Skeving, analyst at the Swedish Transport Agency, Road and Rail Department. Sweden is one of the leading countries in serious injury data collection and has set an example in linking hospital and police databases in order to have a more complete picture. Marie will present how it was possible to achieve these results in Sweden. Marie, the floor is yours.
Thank you very
10
much.
minutes. Sorry, I was just to emphasize, if you weren't there at the very beginning, I'm afraid I have to be very strict with the timings, otherwise we're not going to be able to get through. So without rushing through, 10 minutes starting now. Thanks, Marie.
Thank you. Can you all see my screen?
Yes, yeah, we can see it.
Yeah, okay, great. Thank you so much for inviting me to this PIN talk and this important topic. So I will talk about the Swedish experience and the journey from from police data to hospital data. Let's see if we can move on. So I will start out with where it started, and then I will talk about the information system Strada, where we have all the data. And I was asked to show a data flow chart, so I will do that, and also let you know about the current and future challenges for serious injury reporting. And so it did start with the Vision Zero, and I'm not going to talk about it in the more general sense. The important thing about this governmental proposition in 1997, when it comes to serious injuries, is that it stated that we need data from hospitals to determine and follow up the long-term health consequences of road traffic accidents. So, and this actually changed how we follow up serious injuries in Sweden. So we don't use the MIS 3+, although we do report it. We use the definition long-term health consequences, and but that's for another talk. Now we focus on the MIS 3+. So what we have is the Strada system, the Swedish Traffic Accident Data Acquisition. So this was also stated in the Vision Zero proposition, that we needed a new system that included both the police data and the hospital data to achieve the new goals of focusing on the safe system approach and the long-term health consequences of injuries in road traffic. So the police reports all accidents in road traffic where at least one person was injured and one vehicle was involved. As Jenny mentioned earlier, the definition of the road traffic accident has to involve a vehicle. And for the hospitals, they report all persons going to an emergency department as a consequence of road traffic accidents. And these are also pedestrian-only injuries or accidents. So this picture, I love this picture. It's so old, probably 20 plus years. But here you can see that the police is at the scene of the crash, and they focus on what's happening. They focus on the event, and we get an objective picture of what happened. While the hospitals, they focus on the injuries. This is where they are the experts. So we also get the information about the event, which is most often from the person's or the injured person's view. But here the injuries are, of course, the most important part. And they report according to the AIS system. So we have direct coding in the AIS system. And we have specific staff on the hospitals doing specifically this. So these are trained nurses doing this. They don't do this full time, I should mention. But we have trained them specifically. And this, of course, supports the road safety work on both the national, regional, and local level. And that was the whole point with this new system. So here comes the data flow chart. So I put in an example, Lars Andersson. He has a unique ID, which all Swedish residents get, which makes this so much more easy for us to do. So he has his date of birth and an additional 4 digits, and the digits are numbers. So this is basically what we use to link the data. So the hospitals put in his unique ID, and the police also puts in his unique ID. And then we use that together with the coordinates of the crash, which is put in by both the hospital and the police, and the time of the crash. So this is the foundation for linking the accidents. And of course, in the other end, we don't want any of the names or the unique IDs, etc., to show. So where I sit, the data I get from the system is anonymous or pseudonymized. And if we look at the proportion of the reports, So I took the numbers from 2024. And as you can see, we have a little bit over 11,000 police reports. So this could involve several persons. And the hospitals have 45,000 persons in 43,000 accidents. And very few are actually matched. So here we can learn that the police get to know about accidents that the hospitals don't get to know about. So this is a very good information. And as you can see, the amount of reports from the hospital is huge compared to the police. But here we have the pedestrian-only accidents. So about 28,000 of the persons that we have in Strada for 2024 were pedestrian-only. And this is the journey of data collection in the hospitals put together with MIS 3+. And so here you can see how the development of the Strada system on the hospital side actually have looked like. And so we started to add hospitals. We made decisions or we made deals with each hospital, or maybe a few in the same region at a time. And up until from 2016, we had national coverage. And as you can see, well, I started a bit before. We actually, in 2004, between 2014 and 2015, we made a change in how we use the informed consent. So the patient had to actually have a signature. Well, I'm not going to get into details, but that changed how much reports we could get. And then we got national coverage, about 70 plus hospitals. And then we had the pandemic. Thank God they focused on treating patients and not reporting injuries. Also, of course, not good, but yeah. And then we had the Strada Act, which says that the hospitals has to report traffic injuries, and they no longer needed informed consent. So then you can see the bump in 2021 and onward. So this is what it looks like. It's not very straightforward, but hopefully we can get some stabilized data collection now that all of this is over. So these are the challenges that we have faced. So as I mentioned, during the pandemic, the hospitals prioritized the patients and not the data collection. If there are organizational changes at the hospitals, this might affect the routines of data collection. If there's a change of staff, the nurses that we trained, we're going to need to replace them. Maybe there's a gap between, things like that. So the long-term challenges is the continuity. So we hope after all these years that we will have a stable data collection. What is it, after 30 years, something? So that is what we are trying to do. And just to mention, I'm putting together for the IRTA, the ITF group, I'm putting together a toolkit on how to start collaborations with hospitals. This will be published in April, so I'll be happy to share it if there's interest in that. And yes, thank you so much for your attention. I'll be happy to take any questions.
Thank you very much, Marie, for those insights. We look forward to seeing that toolkit. I'm sure that would be of great help and interest to many of the participants today. So I also like the term long-term health consequences. It definitely makes a lot more sense to me. Next, after Sweden, we go to Ireland. We know that underreporting is a key issue when it comes to serious injury data collection. And Dr. Stefano Castello, who's the public health researcher for the Irish Road Safety Authority and visiting research fellow at the School of Medicine, Trinity College Dublin, is here today to present the findings of a study that focus on underreporting of serious injuries in Ireland. Stefania, thank you so much for joining us. I know you also have a very rich presentation. So yeah, I'll also, if you go over the 10 minutes, I'll give you a 1-minute warning. Over to you. Thank you very much.
Thanks, Ellen. Thanks for the invitation. I'll be talking to you today very briefly on how do we estimate serious injuries in Ireland. So just a bit of background and then explaining the sources of data and our methodology for doing this estimation, and then some results in terms of trends, and focusing on cyclists just for a couple of minutes. So in Ireland, our current road safety strategy includes specific actions to study serious injuries in hospital data. The primary goal of this is to report to the European Commission in terms of mainstream loss, but we also wanted to have a greater understanding of serious injury trends and characteristics, and also be able to compare the hospital numbers with the police data. So the sources of data on serious injuries that we are using currently are police, which is the Irish Road Traffic Collision Database, and hospital records from HYPE, which is the national database of hospital discharge records from all acute hospitals in Ireland. All the information in HYPE is coded in ICD-10 AM. So we use, to detect our casualties of interest, we use the S and T and the V codes. We translate ICD-10 codes into AIS using the AAAM map developed for converting ICD-10 into AIS. And we applied specified inclusion criteria to count a casualty as seriously injured. So we count casualties who were admitted to hospital as inpatients on an emergency basis with at least one injury from a road traffic collision. And these casualties should have been assigned a maximum AIS score between 1 and 6. But before doing these estimations on the hospital sample, we applied a deduplication and data cleaning process to the hospital sample that are key for us having good quality data in the end. So the definitions of a serious injury in each data source in the police and in the hospital data are different. So in police data, a serious injury is a person who was in hospital as an inpatient, or a person with an injury from a list who may have not been in hospital as inpatient. And these injuries from the list may be fractures, concussions, internal injuries, several cuts, among others. And then in hospital data, as I said, we use the AIS scale. So a casualty may have sustained one or more injuries. So we first assign an AIS to each injury, and then the maximum AIS is detected to obtain two subgroups of casualties, the casualties having a maximum AIS of 2 or less, or the maximum AIS of 3 or more. But then we also count all hospitalized casualties, which is basically the addition of MACE 2 or less and MACE 3 plus, counting all casualties together. And that's interesting because with that measure, we can then compare, in a way, hospital data with police data to understand, to have an estimation of how many casualties police data is detecting, because they should be recording all inpatients. So this is some results. First, starting with just an overview of our deduplication and data cleaning steps with the example of 2024 data. So we started with over 5,000 records with the codes, the ICD codes of interest. And then we start applying our inclusion and exclusion criteria just to get included in the sample the emergency admissions. So we exclude, for example, the readmissions. Then we exclude all casualties who died within 30 days since the admission. And then we also exclude non-traffic collisions. And then we get our total of casualties injured in road traffic collisions. And to that sample, we apply the translation into AIS. We exclude unspecified injury severity cases and missing cases who were not successfully translated. And we get our total of hospitalized casualties, which can be divided into these two subgroups. So these are the trends in serious injuries. So in purple, you can see the total of hospitalized casualties, and in teal, the total of police serious injuries over this 11-year period. And then in red, the major plus casualties. And as you can see, there is an upward trend. So in the two sources, there was an increase in the number of serious injuries over the years, a drop during the pandemic. And then another point is that the number of hospitalizations is consistently higher than the number of police records every year. And then you can see in red here the major plus casualties, who are just a portion of all hospitalized, which are also increasing. Now, if we focus for a second in the last 5 years of data, you can see that there were over 11,000 hospitalizations versus over 7,000 serious injuries in police records. So the ratio hospital to police is 1.5. So there were 1.5 hospitalized casualties for each serious injury recorded by the police. And then you can see that the underreporting of police varies by road user. So, for example, for car users, the ratio is 1.4, it's not as high, but then for cyclists, it's 2.5. So there were 2.5 pedal cyclists in the hospital sample for each serious injury in the police sample. So when we started to get the first results of this project, we wanted to understand the reasons for this large underreporting of cyclist injuries in our local context. So we started studying the cyclist sample in more detail. So I'll show you some insights from that study, and then how do we report on serious injuries using all the available information. So focusing on cyclists, so single cyclist collisions seem to be like one of the reasons why we have this large difference between the two data sources. So you can see here the total of hospitalizations among cyclists who were in single cyclist collisions, and then the total of single cyclist collisions recorded in police data. So there is a huge difference between the two data sources. There were over 9 hospitalizations from single cyclist collisions for each serious injury from a single cyclist collision in police data. You can see that this difference between the two data sources is consistent over the years, and that there is a huge increase in the number of single cyclist collisions during the pandemic, which is also interesting. Single cyclist collisions in police data accounted only for 18% of all cyclist injuries, because they are mostly recording collisions with motor vehicles. But in the hospital sample, we have 69% of all cyclist hospitalizations being from single cyclist collisions. So that's a huge difference. And also 64% of single cyclist collisions accounted for 64% of major plus injuries. So how are we reporting on serious injuries using two separate data sources? Well, we are preparing these summary reports with two sections. The first one focusing on the collision characteristics, focusing on police data, and the second section focusing on the casualty characteristics using hospital records. We are taking the two data sources as complementary. And we also prepare full reports, but we focus on the summary reports to include data from the two sources. So this is how the first section using police data looks like. So we basically describe the date and time, the road type, all focusing on the collision characteristics, the contributory actions of the casualty. And then the second section focused on the casualty profile and the injuries sustained, and this is all based in hospital data. We also have information on the admission to hospital, how many days they spend in hospital as inpatients if they sustain clinically serious injuries, what was the destination at discharge. So all the health-related information, let's say. So the key messages from these presentations are that studying hospital records is key to address the underreporting of serious injuries in hospital data, that there is an upward trend in the number of serious injuries in Ireland, counting all hospitalizations and also Mace plus injuries, that the underreporting of cyclist serious injuries in police records is noteworthy, and that this difference is in part explained by the large proportion of single cyclist collisions in hospital records. We are taking police and hospital data as complementary because they provide very valuable information to obtain a more holistic understanding of serious injuries. But we still have gaps of information. For example, e-scooter serious injuries are not very well captured in police or in hospital discharge records. So we are trying to study other sources of latent serious injuries, in particular to address this gap in e-scooter injuries, including emergency room data, pre-hospital services, major trauma, registry data, and we are trying to get in contact with colleagues from the rehabilitation sector as well. So this is just a list of all the reports that we've been preparing and publishing in the last 3 years. So you can go into our website to take a look. There is, as I said, the summary reports and full reports as well, and FAQs and the methodology that we use to estimate serious injuries, and to acknowledge the contribution of the health service executive, which is collaborating with us to study hospital records, and also to our colleague researcher in Trinity College Dublin, which is also a collaborator of the Mace Plus project. So thank you for your attention.
Wonderful. Thank you very much, Stefania, for that excellent presentation, very clear explanation on the challenges of underreporting and what you found there. Also giving some confirmation of some of the priorities that we need in terms of the countermeasures. So moving from Ireland to Finland, one of the main issues when it comes to serious injury data is to convert ICD codes from hospital registers into AIS codes that could be used to collect data based on the MIS 3+ definition adopted at EU level. So this is also what Peter has mentioned. Finland has done a study into it, and today Nora Araksinen, Chief Specialist on Road Safety at the Finnish Transport Infrastructure Agency, will present the findings. The floor is yours. Oh yes, just one more request to our audience. Please be more active. There are a lot of you there. Please send us some questions that you may have for these excellent presenters here. So we'll take a break for some questions after the Finnish and French presentations that are coming next. The floor is yours, Nora.
Thank you. I hope I can get this to presentation mode now. Does it look good or?
Not yet. We'll just
no.
be patient. We'll just be patient another moment.
Yeah, it looks good for me.
Oh, that's very odd.
Yeah.
Do we have this as a backup amongst ETSC? I think we have this one, don't we? So
I think is it now.
Hang on, we'll try. Yes, perfect.
Okay. Yes.
Thank you.
Okay. Okay. Hello. Nice to meet you all, and thank you for the opportunity to participate as a panelist this interesting event. So now I will quickly tell you about Finland's experiences of the conversion of ICD-10 codes to AIS severity classification. Let's see if this moves forward. Yeah. Okay. First, very brief overview of the key points about the reporting process for serious injuries in Finland. The current method we have was developed in 2040, and the regular reporting of serious injuries started in 2015. And the basic elements of the process are our national care register for healthcare, and we use the MAIS3+ criteria and the ICD AIS map provided by AAAM. And the reporting process itself is annual, and what we do every year is that based on the personal identification number of the persons involved in traffic accidents on police statistics, or based on the ICD-10 external cause V00 to V99, the patients involved with traffic crashes in care register are identified. Then the identified patients' treatment periods, outpatient visits, and the ICD-10 injury diagnosis S00 to T79 from the care register are extracted. And as a result, we have 2 data sets, including the patient's treatment periods, outpatient visits, and the ICD-10 injury diagnosis from the care register. And the data 1 is the one which is based on the personal identification number from police statistics, and the data 2 is a data based on the ICD-10 external cause. And after that, we process these both data sets according to certain very detailed principles, including, for example, linking the accidents and treatment periods and outpatient visits, and removing the overlaps between these 2 data sets. And then we do the classification of the severity of all injuries using the ICD AIS map, of which I focus on next 2 slides. And Statistics Finland is the responsible for the reporting process in practice in Finland. Okay, wrong direction. Then the converting process itself, which is technically very easy and simple. Based on the ICD-10 injury diagnosis codes, the ICD AIS map determines if the injury is minor, which is the value O and corresponds to AIS 1 and 2 classifications, or it's serious, which is the number value 1, and or cannot determine, which is the value 9. And all patients with at least 1 AIS 3+ injury are considered as seriously injured persons, which means the MAIS3+ criteria. And the conversion result is not perfect, but for now we can live with it. And now I will tell you a little more about the conversion results. In Finland, we have 2 studies conducted on the reliability of the ICD AIS map by comparing the results with the severity classification defined by an expert, which is the correct way to use the AIS classification. And this slide has compiled the results from 1 study using Helsinki trauma register data, in which the patients have multiple injury diagnoses, as they have in our care register also. I will not go through all the details which are in this slide, but as you can see, we have identified all the diagnoses for which errors occur. However, not all of them are relevant for identifying seriously injured patients. For example, if a minor diagnosis cannot be found from the map, or a severity classification cannot be obtained for it, it's not a problem, because we are interested only in the serious diagnosis, of course. But there sure is some problems. First of all, injury codes. In the study, the 72% were converted correctly, and the most errors occur when the serious diagnoses were classified as a minor. This is the 12% of all diagnoses, or the code was missing from the map, and this is something like 10% of all diagnoses. And here I have described the most common and therefore the most problematic diagnosis codes, which are the multiple fracture of ribs, the S22.4. According to AIS classification, a fracture of more than 2 ribs is serious, but this code does not specify that. It includes all more than 1 rib fracture, and the map converts always these diagnoses directly to minor injury. Then there are the visceral organs, which can be either serious or minor, depending on the details of the injury. For example, whether it is a bruise or rupture of liver or kidney, for example, but the code does not specify these details. So all of these injury codes are classified as minor in the map. Then there are fractures of extremities. There are several codes which don't separate if the fracture is open or not. And according to AIS classification, open fracture is usually serious injury, but these codes are classified as a minor on the map. And there are also a few specific head injuries, with, for example, prolonged unconsciousness. And the code does not indicate whether there is unconsciousness or not, and for how long. So these injuries, some of these injuries are misclassified. So the major problem is that the injury codes which are used in Finland are not detailed enough. The problem is not the ICD-AIS map, which cannot work correctly if the codes do not indicate the severity of the injury. Okay, then I will also quickly show you some results and time series. Here you can see the number of seriously injured in Finland since 2040. The main points are that the largest groups are cyclists and car or van drivers or passengers, and the trend is not decreasing, which is a problem considering our goals. And currently the latest figures, as you can see, is 2023. Which means that from the traffic safety perspective, we have too long reporting delay. And the figures 2024, for example, will be not available until January 2025. And to mention that in the future, we will also be able to separate the e-scooters because we now have our own code for them. It's the V00.8. Then the same thing, but there is the division into two data sets I mentioned earlier. I emphasized that only less than half the data one of the seriously injured can be found in police statistics, where is good background information of the accident, and more than half the data two are only in healthcare register, and there is not enough background information for effective traffic safety work. For example, the location of the accident. And large part of these cases in data 2 are cyclists. And finally, considerations first regarding the conversion. Based on our studies, the ICD-AIS map underestimates the number of seriously injured by 21 to 34%. And the different results are explained by whether the research data contains many or few seriously injured patients. And as I mentioned earlier, we are very aware of the problems, and our ICD-10 codes are not detailed enough. The map includes more detailed codes, but many of those are not used in Finland. We also know that there are some errors in coding ICD-10 external cause and diagnosis in care register. We know that mainly the diagnosis and external causes are recorded because the coding itself is mandatory in Finland, which is good. However, not all doctors always record everything correctly, but serious diagnoses are usually recorded more comprehensively than the minor ones. But unfortunately, we don't know exactly how the possible errors in coding might affect this reporting process. Then considerations regarding the reporting process. I've already mentioned these first 2 points, the lack of background information and the reporting delay. But which is good thing is that we have established method now and quite long time series already in use. And the data is valid for reporting trends. We are also aware of the shortcomings of the method, and I think this is a strength because it's very important that we know where we should put our efforts to improve the method. And the method also clearly highlights the lack of coverage of police statistics, and that's for sure. And this can also be seen as a strength because based on this data, we can easily point out the main problems of our statistics, for example, to decision makers. And what are we doing about these problems? I mentioned we have started an investigation of accident resulting serious injuries organized by the Finnish Crash Data Institute. We utilize all possible existing data sources, for example, the insurance companies and from the emergency care. And the investigation aims to solve the problems I have presented, particularly the reporting delay and the identifying serious injuries. Unfortunately, at the moment, we do not have enough resources to investigate all serious accidents, but it is our goal for the future. And I myself am involved in this investigation. I find it very interesting, but it would require its own presentation. So I think my time is up now, so I will end my current presentation. Thank you for your attention.
That's it. Thank you. Thank you very much, Nora. It's super interesting. Yeah, and we'll be coming back to that question about the trend, the reduction of serious injuries declining more slowly than deaths when we have our question time session. No, but thank you very much for making something very technical much more accessible. And I'm sure I'm not the only person to think that. Right, now we move to our last speaker in this panel. So from Finland, we zoom south to France with the magic of Zoom, the internet. Céline Vernet, researcher at the Gustave Eiffel University. You'll be presenting us the French case where data on serious injuries are being estimated based on the Rhône registry. Over to you, Céline. So yeah, 10, 12 minutes. And then this is your last chance, dear audience, to think of questions. There is one already. Thank you very much. So please put them in the Q&A box. Over to you, Céline.
Thank you very much. Can you see my screen correctly?
For the moment, it's still in, it's not in full presentation mode. So if you could try to click on the, yeah, perfect.
Does that work?
Thank you.
Okay,
Yes.
perfect. Thank you very much for the opportunity to present our work to estimate the number of seriously injured in France. And it's the methodology based on the Rhône World Trauma Registry that I will present you today. So just for the introduction, why do we need a methodology for national estimation, and why don't we just not measure the number of seriously injured in France? And this is the same results that we can see here and that we had in the other presentation previously from the other panelists, is that when we compare police data with health data, we can see differences of depending on the geographical area and the type of road user and several other characteristics. We see many differences between the two data sources. So we really need to improve the number in order to have the more reliable picture of the number of casualties from road crashes in France. So what is the methodology that we use for the national estimation of seriously injured in France? So it is a little bit different from what you have earlier. It's in France, we use a capture-recapture approach with two sources, so the police data and also the Rhône World Trauma Registry. And we talk about those data later in the presentation. And before using the capture-recapture approach, we will use an additional step before applying all those steps. So the data, we have the French National Police Database of road traffic crashes. That means that police has to record road crashes involving at least one vehicle and at least one injured casualty. And it's done at the national level. So you can have data at the national level, but also at different subscales, just like, for example, for the Rhône County, which is an administrative area. So we can work on this specific geographical area if we want. And in this kind of data, we have injury information. Mostly it's based on the hospitalization status, so it's not based on the MAS or MAS status. And and define slightly and seriously injured based on the status of hospitalization. And we also have in our geographical area of the Rhône County, we have also the Rhône Road Trauma Registry structure, which is a structure that started nearly 30 years ago. So the Rhône department is a small department, so a small division of France, but it includes Lyon, which is the second French metropolitan area. And the Road Trauma Registry relies on the network of more than 250 units in 50 hospitals or clinics. It's based on health data. And so these units include all the units that can take care of a road crash casualty. So it means that it includes emergency medical mobile units that we have in France, emergency rooms, and also it goes up to rehabilitation departments. So for the population that we have in the registry, we try to include all casualties of road crashes that occur in the Rhône department and who went or were brought to a private or public healthcare facility because of their injuries. So we have hospitalized and non-hospitalized in the Rhône Road Trauma Registry compared to what you can have in different type of health data in France. For example, in national hospital discharge data in France, you have inpatients only, and in emergency departments, it's mostly outpatients only. So that means that the Rhône Road Trauma Registry is more comprehensive about road crash casualties. What about the method? So as I said earlier, we use the capture-recapture method, but we need several conditions. I will go over that very quickly. Of course, we have to be in a similar geographical area and the same time period in order to do the estimates, because it will not mean anything if we don't have this condition fulfilled. And we need a perfect identification of subject of interest. We also need 4 key conditions, and this is what is really important here, because we need to have a close population, a perfect recall linkage, but most of all, we need independence between sources. So, which means independence between police data and the Rhône registry data. And we need also the homogeneity of capture to be able to have reliable estimates. That means that for a given source, the different casualties should have the same probability of being recorded, whatever the characteristics. And we'll see that is a problem that we have in French data. About these 2 last key conditions, we know that there is a dependence between hospital and police data because we have matched cases. But we know from the literature that the estimate that we have will be a lower bound. So we don't overestimate the number of seriously injured using this type of method. And about the last point, which is we should have a report that is homogeneous. According to the literature and from the previous work that was done in our team, we know actually that it varies, and it really varies depending on injury severity and also on other characteristics of the crash, just like the mode of transport, the involvement of a third party, the type of road network, the type of police, because in France we have different types of police. We have gendarmerie and the police, and different type of police nationale, police municipal. So it really depends on the type of police and the other characteristics. So in order to take that into account and to really have reliable and robust results, we need extra steps to add to the capture-recapture methods. We need to add a step, which is an MAIS predictions before capture-recapture, so we can have the information in both database. And we need also, for the capture-recapture method, a more complex modelization than just the stratification that is usually done in order to have more reliable estimates. So what are the steps that we are doing to have these estimates? Here is the full procedures that we are doing, and I will go over each step separately. So the step one, as I said earlier, is a pre-step that we have to do. We have to predict the MAS 3+ status versus MAS 1 or 2 in police data, because it doesn't exist in police data. And to be able to apply the capture-recapture method, we have to have these data in both datasets. So first, the first step is divided into two small steps: the prediction of MAS 3+ in the RON level using the road trauma registry and the police data matched cases. And we will use the variables available in police data to make a prediction of the probability of MAS 3+ on the matched dataset from the logistic regression, but we can also use other models that works if they can work. And after this step, so we have this prediction of the probability of MAS 3+, and we will use this probability of MAS 3+ to apply it in police data from the wrong county, but in the police data only, so not on the overlap, but in the other part of the police data where we don't have any information on the MAS status. And after doing that, we also apply this prediction to the nationwide police data. So at the end, we have predicted or observed MAS 3+ for all casualties observed in the Round County, but also at the national level. So after those steps, we have information on the casualties that are recorded in the different databases and in police data. So after, we really need to estimate what is the actual number of seriously injured. So this is the next step. We apply the capture-recapture approach. We apply it at first at the Round County level. And this is where I say that we use a more complex method. I will not go into details in that, but we need in this model information about variables associated with underreporting. So we know that at least we need information on MAS, we need information on type of police force in France, on the mode of transport and the third-party involvement. And if we want to provide results according to age or sex, we also need to have these variables in the model. So that model will provide the coefficients that we will be used in the last step to correct for underreporting for the different profiles. If you don't go over this complex model, you can use a simple version of the capture-recapture method using stratification and estimate the coefficient for each strata. For example, a strata is a mode of transport, a crash opponent, and an MAS status of 3+ or 1 to 2. And the last step, as I said, is to apply these coefficients that were provided through the model or the stratification to the Round County data if you want estimates at the Round level, and you can apply those coefficients at the national level on the national police data to be able to have the national estimates of seriously injured casualties. So this is what we apply in France. Thank you very much.
Super. Thank you. Thank you very much, Celine. It was excellent presentation. Also trying to do with to show what to do if you can't get all the data, different steps. Thanks very much. So I'm bringing back into the screen now all the speakers we've had so far for our Q&A session. Thanks for waiting patiently, and to the participants who are waiting to hear about countermeasures, like what are we going to do to tackle these the levels of serious injury in Europe, you'll have to stick around for part 2. Okay, but now part 1. We've got one question which I'm going to pose simultaneously to Jenny and Peter, please. So, is data from hospitals on all patients recorded in all EU countries? So simple question to Jenny and then to Peter. If yes, is it mandatory to make this data public? Also quite simple, but what does that bring up? Thanks for the question. First to Jenny.
Yeah, I don't know if I know the answer to whether, I presume all hospitals record the patients that come to them. Perhaps some of the experts here can correct me if I'm wrong. I think the question really, when we're talking about serious injuries, is that second part of that question is, does it have to be shared? And we did ask that question, whether it was mandatory for hospitals to share their data. And yeah, it was a mixed picture. I think it's probably mandatory in around half of the countries, PIN countries, and in the other half it's not. We have some examples in our report of how that data is shared. Sometimes, I think it's in the Netherlands, it's shared for research purposes, so you can request it, and you can do your research for it, but they don't get it sort of on a regular basis. It has to be requested. So yeah, it's a good question. I think the data is there. Whether it's mandatory, it can can improve the situation if it is mandatory, but that's not the case everywhere. And I think if we look at Marie would tell us that in Sweden it took a long time, I think, to get that data from all the hospitals, and it's not a simple job, even just by making it mandatory. So it's a good question. But we have some examples in our report of if it's not mandatory.
Peter.
Yes, well, I can have a go at the first part of the question, and I'm glad Jenny was able to answer the second part with the detail from the report. So I think the challenge that we have is that we need dual coding in ICD-10 to be able to determine the sort of nature and the mechanism of a serious road crash. So that there are V codes and S&T codes. And the S&T codes then describe the nature of the injury, so as a skull fracture or other type of injury. And so those are the codes in the AAAM mapping, which determine which injuries constitute an MIS severity 3+. But we need the other codes, which is the V codes, to determine whether they're caused by a road traffic crash. So there are a lot of detailed V codes, so a crash with a pedestrian and a car, or pedestrian and cyclists, and so on. But in our experience, dual coding is not routinely undertaken. So that's the difficulty. I know, for example, in Greece and Bulgaria, that when we have had discussions with them, they don't have these V codes, so they can't determine. They know the severity of the injuries, but they don't know whether it was caused by a road traffic crash. So that's the big challenge. Yeah.
Okay, thank you. Thanks very much for that further elaboration and clarification. So next we have some questions to Celine, please. If you could indicate the different correction coefficients for the different road users. So very specifically, what is it for pedestrians, cyclists, motorcyclists versus the motorized road users? i.e., what is the underreporting level for the different road users?
Okay, so we are currently working on the new coefficients to correct for underreporting. So I will not be able to provide the coefficients that we can use in France. You also have to be very careful, because we are extrapolating the way that the police in France report the road crash casualties. That means that it may not be usable and transferable just like that from one country to another. You really have to work on your own data. You should be able to find a part of those coefficients maybe in the French Road Safety Observatory reports that they publish every year. Yeah.
Okay, thank you very much. So on the topic of underreporting, Stefania, do you think that there's a similar trend of underreporting of serious injuries also in other European countries? And what can we do to improve? Is that like the $1 million question, but what can we do to improve the data collection? Thanks.
Thanks, Ellen. So yeah, I think it's been widely recognized that police records are underreporting the number of serious injuries, and this is something that we see in reports from other countries across Europe. I think that has to be with the way in which police are recording the data. They are going to the scene of the crash. They are not medics, so they cannot correctly assess the severity of an injury, or it may be the case that the casualties start feeling unwell later on, during the day or at night, and they go to hospital directly without alerting the police. So there is a number of factors that could be influencing the underreporting. But I think that using hospital records for us in Ireland has been very, very useful to obtain better estimates, to get to know, for example, the scale of the issue on single cyclist collisions, which wasn't known until we started to look into hospital records. So I think what can be done, like I suppose, trying to get access to other sources to complement the available information, to collaborate with the health sector. For us, that's been very, very important to have collaborators from the health sector to provide us, advice on how to, for example, clean hospital records, how to interpret the outputs. And also, I suppose, if we go to the hospital level, if we improve the coding, as Peter said, if we have good information, we will have good then codes, and then we could do a better translation, and we can have better estimations. So I suppose informing the hospital sector on the importance of their information and on the importance of the coding, I suppose that could be another way. Yeah.
Thanks. Thank you very much, Stefania. So another question I have for Marie, as a policy person at ETSC, I'm very interested in how we can use the serious injury data to inform policy decisions. Can you give us an example of how that's already been applied in Sweden, perhaps? Thank you.
Yes, thank you for the question. I think the major big change that kind of happened organically when we started collecting data at hospitals is that we now shifted the focus from the motorized vehicle accidents to vulnerable road user injuries. So that's, I think, the major change in policy view. So now, instead of focusing on building big safe roads, which we still do, of course, but now we also focus more on the vulnerable road users and their injuries.
Super, thank you. So yeah, that's a big priority, of course, for us as well. Nora, in your presentation, one of your last concluding slides there, you were talking about the challenge of the lacking background information. So do you think that an improvement in police reporting could be beneficial in order to reduce the lack of background information in serious injury cases?
Yes, it could be, of course, but to be honest, I don't think it's the answer to the whole problem. For example, in single bicycle crashes, the police are not really needed in the accident place because there are not usually need to resolve any guilt issues or investigate violations or things like that. So I think they can't be expected to be there, and their resources are also limited. So in general, the problem should perhaps to be solved in a different way. Some other information should be used. But still there is a room for improvement in police reporting, because there are, of course, cases that should be reported by the police, but they are not. So at some level, that would be the answer. Yes.
Okay, thank you. Thanks very much. So last question to Peter, please. We're all sitting on the edges of our seats waiting for the upcoming strategy implementation report. So that's the EU road safety strategy with the targets of halving road deaths and serious injuries by 50% by 2030. We're 2025 November. Have you got an update for us, please?
Sorry, I missed the first part of that question.
Yes, so could you give us an update about the strategy implementation report?
Right, yes, of course, yes, right. Yes, well, we're in 2025, we're at the midpoint of the decade, and that means we're also at the midpoint of the EU road safety policy framework. So we're currently finalizing the preparation of a so-called midterm implementation report on this framework. The report will be an overarching document setting out the developments at EU level, so what we've done so far, and it will also set out the challenges and opportunities for the future, and it will be supplemented then by 27 country-specific profile reports. So again, taking stock of what member states done at the national level, how they've delivered on their own strategies and action plans. And the report is expected to be published as a Commission communication then by the end of the year or early next year. So it will have a lot of examples of good practices from member states and successful strategies and approaches, as well as areas that need improvement. So it requires a bit more patience. We're anxious to publish as quickly as possible, but there are a lot of steps, as you know.
Yeah. Okay. Well, we cross fingers that will see the light of day soon, because I think this would be very, very helpful, given the current state, as was outlined by Jenny at the beginning, and yourself as well, in terms of in the area of serious injury, the slower trend. So before we break, I'd like to again virtually applaud all of the speakers' brilliant presentations. Thank you very, very much for all the effort and preparation that went into that from our first panel. We've been together for an hour and a half, so we're going to have a short break. I see we've still got a lot of people with us, 93. Thank you very much for coming. Come back again for panel 2, because that will be looking at the countermeasures. So what can be done to tackle serious injuries specifically. So see you back here in 15 minutes, get some fresh air, have a cup of coffee, and we reconvene at 1:45. Thank you very much. Bye-bye. See you soon. So welcome back, everybody. Just a reminder for the participants, please put your questions for our next group of speakers in the Q&A box, and we'll try and answer as many of them as we can in the last part of the session. So this part 2 will be looking at reducing serious injuries and what can be done. And we have 4 excellent speakers. So Veronika Valentova is our first speaker, talking about infrastructure, safer infrastructure. Then we're going to look at powered two-wheelers, male and female risk. And then lastly, one of the topics that's been mentioned often already so far is looking at single bicycle crashes and what can be done from the perspective of infrastructure. So now I pass over to Veronica, Director of Research at the CDV from Czechia.
Good morning,
Veronica.
everyone.
Hello.
Thank you.
So you're going to present how safer infrastructure could help in reducing the number of serious injuries. Over to you, Veronica.
Thank you, Ellen. You should see my presentation now.
Yeah, it looks great. Thank you.
That's great. I know I have just 10 minutes. I have timer here, but it's really challenging for so big topic like forgiving road design, because what does it mean? Forgiving road design is a design philosophy which is connected to all civil engineering constructions. The use of each construction must be safe. And for road infrastructure, it's a little bit different, because speeds in which we use the infrastructures are 20 times, 40 times higher than is usual in our civil buildings. So it's a design philosophy that the probability of mistakes and the consequences of mistakes must be reduced or eliminated. And the key principles for the safe road design and forgiving road design is that the design must meet human expectations. And for this principle, we have categorization of our roads and streets, and we need to provide recovery opportunities for the cases when we make a mistake. And the other thing is that we should minimize the hazards on the road infrastructure, and obstacles are the most convenient ones. So the human perception and physiological, but also physical, environmental limitations are very important. As you can see in my pictures, the viewing angle is changing with the speed of the vehicle. Our abilities to see all possible possibilities on other infrastructure and the destruction, and to paying attention to several objects at one time is very exhausting for our minds. And as I talk about the physical environment, if there are some limitations on the horizon, you can't see the vehicles in opposing direction, or cyclists in your directions, and so on. And there are still situations you can't predict, like the animals on our roads, because we know that for cyclists and motorcyclists especially, they are very dangerous in some cases. So the road categorization and the hierarchy of roads and streets is the basics for the forgiving roads, because they have different functions and they have different purposes, different types of users, and the users have different expectations. If we will talk about motorways, there are restrictions for entrance. If we are in the cities, we can have separated pathways for cyclists and pedestrians. On the other cases, we can have mixed traffic with the public transportations, cars, cyclists, motorcyclists, pedestrians, everyone in one place. And we need to not forget that the streets especially don't have just transportation purposes. And the function of the street is it's a part of public realm. We want to have 15-minute cities, livable cities, where people really want to live, have fun, make shopping, make eating, and other activities. So it's not just about transportation, but if you are a user of transportation, you shouldn't be distracted so much by that. So all of this is making a perspective for road design, and as a road designer, you should focus not just on the transportation, but also on the other purposes. And what are the most important parts for forgiving roads? I was talking about the perception, but important are clear zones. Clear zones, you can find many publications decades ago which were focused on this topic. You can see in the pictures the red lines showing the clear zones. You can see that there are different types of them, and the width is different, and we really don't know which different is sufficient. And you can see also the picture in mountains where there is no recovery zone. It's really solid, and it can be a big problem if you will drive speed, but usually you will behave as you expect, so the speed won't be so high. What's also important for the clear zones is that the shoulders, especially the unpaved shoulders, shouldn't be dropped or raised because of the inappropriate reaction of the driver during the recovery maneuver. And also the condition should be good that there is no risk of sinking of tires, which is very dangerous, especially for motorcyclists. But how these clear zones should look like and what can we expect? I got a short video from Czech newspapers. It's a video from a driver, and even if you can think that this road is safe, there's a pedestrian pathway nearby. Please look at the truck. That was very severe accident a few weeks ago in Czechia. The truck driver had some health issues and he went out of the road, hit the woman and then went back. The driver didn't know that he hit someone. After the call from the police to his employer, this driver immediately reacted to the police that it was him, and he had some health issues. The woman was seriously injured. Thanks to the people who were there and helped her immediately, she survived. But my question is, which distance is sufficient? You can see that it's more than 3 meters and paved shoulder there, and it's not enough. Sorry, I wanted to go to the next slide, and I started the video again. With the clear zones and recovery zones, obstacles are closely connected. And here you can see the graph from our in-depth accident study that in the higher speeds, the red colors dominates its fatal injury or almost a fatal injury, very severe injuries. And you can see also that the diameter of the tree or pole also is important for this. And now I have several pictures there. All these accidents are preventable and we can do something with that. You can see that the trees are quite far from the road. The slopes of the ditches are okay, but still it's not sufficient and it can be very dangerous. It can be dangerous also in the urban area where the speed is not high. There was a woman driver in that car. She wasn't speeding, and the consequences were very severe. So even in the city. And this is not about the obstacle, but this is about the downfall, where if we miss barriers or guardrails with sufficient protection for drivers, but also cyclists, motorcyclists, it can have very severe consequences. And as I have just 1 minute, I would like to look on some further steps. We know what to do for forgiving road design in traditional mines. We have guidelines from PR, we have guidelines for ETSC. 1998, the forgiving roadsides materials were published. But we still need implementation, and not just on the TEN-T network, where we have many mechanisms for road safety, like audits, inspections, network-wide assessment, but also on the lower class, where we have many obstacles which are not protected. We also need to focus more on education of all professionals involved in the process of the whole life cycle of the road, not just for the preparation of the new road, but reconstructions and maintenance work. We also need to focus on not making confusing recommendation, because it's very simple to say what not to do, but it's very complicated to make some general recommendations what to do. Because every location is a little bit different. There are many parameters you need to focus on. It's not just about the obstacle, it's about the whole road, curves, slopes, and other things, and also the traffic on the road. And we shouldn't rely solely on new technologies. Technologies are not solution for many things. They can prevent some cases, but there are often cheaper solutions which can help if we will make them on a systematical view. And we also should focus on the research how to implement new applications and technologies like artificial intelligence, machine learning, to do what we know what to do, but do it more effectively. And we also need to evaluate the design parameters for new types of vehicles, like micromobility, cargo bikes, but also automated vehicles have different specifications. And we should develop and update our design standards in these topics. And last but not least, new materials and devices can also help to prevent and lower consequences of crashes. We all make mistakes. We all are moving on our infrastructure, but we also want to go home safely. So we need to stay in the right direction. We pushed in the Europe in the last decades, and if we can say that we are the #1 in the world, road safety is that topic. But still, we have a lot to do. So that's all from my side. Thank you very much.
Wonderful. Thank you very much, Veronica. Also for your very wise words there in conclusion. Yeah, so I'm noting that it's about the whole road and the traffic, and that we know what we need to do. We just need to do it. We'll come back to you during the question time. So to the audience, please send any questions that you have to Veronica via the Q&A box. Now, I would like to introduce another great colleague and friend of ETSC, Martin Winkelbauer, our leading expert on powered two-wheelers. He's the senior researcher at the KfW in Austria, and today he's going to present various protective equipment for powered two-wheelers that will also help in preventing serious injuries as well as deaths amongst powered two-wheeler riders. So thank you, Martin. The floor is yours.
Thanks. Many thanks, Ellen, for this extremely nice introduction and for giving me the opportunity to present my ideas on what could be effective measures in the future. I will try to share my presentation now with you. It should be this screen here. Yes, you should see it now.
Yeah, all good.
Okay, let's go. Christmas approaching. Let's see who's naughty or nice. We actually observed around 15,000 riders in terms of what kind of protective equipment they are wearing during the last 10 years. To do that, first I have to tell you that there's no big change to be observed in this data, so I present it all together. So actually, the darker the worse, meaning that the naughty guys are the scooter and moped riders. We put them together here, and a motorcyclist, actually, motorcycle in these terms is anything with a tank beneath your legs. those people in particular, if they drive outside urban areas, they have good protection, while urban scooterists and mopedists, they are driving more or less naked.
Sorry, Martin. Sorry, could you just
Yes?
try to click the full presentation view? Because at the moment we've got.
Okay, sorry.
No, they're great slides. I'm just trying to give them the best view. Okay, try again.
No, I have to share again, I think.
Thank you.
Share again. Better than that this time?
Yeah. Yes.
Sorry. Sorry, I got actually the wrong. I got 3 screens in front of me, so I took the wrong one. Sorry. So let's go further. We have the naughty and nice guys, as you see. So the nice ones are those with the tank beneath the legs, and the least protected actually is the upper body, and I'll come back to that. The upper body of urban scooterists and mopedists. So what can we do about that? First, we have to take well, we heard a lot about injuries and crash statistics today, but my task now is to look at motorcycles. So what we here see in the severe injuries, not the minor and the moderate ones, but the severe injuries, we obviously have a problem with the legs, and we have a problem with the upper body. This data actually comes from, on the left side, it comes from an in-depth study we did together with the Technical University of Graz and their data. And on the right side, you see results from hospital surveys. Actually, we asked about 15,000 people about their injuries in after treatment. So what we don't have here is the really slight cases where people do not return to after treatment, and of course the really severe ones because they can't go to after treatment anymore. So what we see again here, we have problems with the legs and we have problems with the upper body. So this is what we actually have to focus on if we want to avoid serious injuries. Look at the next one. So upper body, I promised to come back to that. That's rather new. Yes, in the last 10 years already, we hear about airbag jackets for use on motorcycles. In early times, they used to be connected to the motorcycle with a ripcord, which is not necessary anymore. So you already have electronics. And of course, it was interesting whether it works. And the answer to that, at least by ETSC, the German Automobilist Club, is yes, it works, but they find a limited potential at higher speed. A French study also done on severe injuries found out that there is limited, so the triggers and all of the stuff, the electronics, that all works perfectly, more or less. Collisions are well detected, but they also find limited potential at higher speeds, and they say the limit is 30 to 40. Another study on that done in Germany, they actually protected, and I'll come back to that as well. They found that there is potential in making these airbags slightly tougher to make them work also at higher speeds. And I also did my own study on airbags. Actually, I talked to 34 people from a motorist club in Upper Austria. And if you're interested in this, the study was already published at the IFZ Motorcycle Conference a year ago. However, I had 25 airbag users among them. Now my contribution to underreporting, 20 of these 34 cases where 28 crashes were involved were not reported to police. No ambulance, no police at the spot. So what I actually found in technical terms is that an airbag is really good at protecting you when you fall off the vehicle, not if you crash into something in particular, not if you crash into oncoming traffic. I promised to come back to that as well. So probably we need slightly tougher airbags, so they could also probably provide injuries of the clavicle or the shoulder, which were the only body parts that really were injured among the interviews who were wearing airbags. And of course, they had injuries in the body parts which were not protected by airbags. So now you can enjoy together with me a couple of videos of airbag deployments. We tested them. I give you a couple of seconds to look at that. On the right side, you see, well, these really tough guys wearing a top airbag, which is typical for German driving schools. And you see the nice guy in the center, that's me. And the left one actually is one for riders. And this is my colleague Rafaela, who likes to, well, the Americans say horse riding, don't they? Okay, let's go further. Years ago, well, even if we thought of making wearing protective equipment mandatory, we could not have done that because we would not have known what protective equipment actually is. But in 2020, most of the standards were published, which now exactly determine what is protective equipment in terms of motorcycles. We also have standards on the protectors, actually, so we can now exactly determine what is good or what is bad protective equipment. But one of the problems actually is, would you know what is good or bad? So neither the motorcycle riders in my study actually did. So what I propose here is to make it more accessible to identify for a purchaser of a protective equipment to see what is really good or what is less protective, if I may call it that way. So people want to buy 5-star cars, so probably they want to buy A-graded equipment, but they need to know, and it is too complicated. That's what the interviews actually said. It's too complicated by the stickers we have now in the protective equipment. So let's go further. Obligations. I don't want to tell you about the things that had happened 30 years ago, but in the meantime, we still have no obligations. You know, motorcycle riders are not quite in favor of being obliged to wear protective equipment, but some of the courts already realized that it is common sense. Everybody knows that protective equipment is there and it's good to wear it. So they reduce the compensation for pain, at least in Austria in general terms, by 25% if you have not been wearing protective equipment. And since a younger court case, we also know that this is also valid if it is 35 degrees outside. If you go outside urban areas, we have no information yet what the courts would say about urban crashes. Something also rather new on the scene is the multi-directional impact protection system, which means that you get rid of this rotational problem where the brain actually stops inside the skull, and all the small vessels around, they actually tear. So that is what MIPS actually does. If you want to know more about that, FEMA is hosting a webinar next week on 10th of November at 7 p.m. Central European Winter Time or something like that. Have a look at the FEMA website and get more details about that. Of course, thanks to Veronica, we now know that it is nice to have the roadside clear of obstacles. So that also goes for the nice chevrons which you need to find the curve. You could replace them by road markings, for instance. However, if you hit one of these steel poles, that's probably not going to end up quite healthy. Or if you hit the concrete drainage tube underneath this protective thing, it might not be quite healthy. The steel poles actually can be replaced by this plastic stuff, which you're probably gonna survive. Well, it's not quite clear whether slightly or severely injured, but at least less injured than if you hit one of the steel poles. So I already come to the conclusions. So it is not necessarily the case that the least protected part of the body has the most injuries. What we actually have seen least protected is the upper body, and most injured are the legs. However, it's quite close to each other, so people, please wear boots, wear nice jeans, protective jeans. You can even have nice protective jeans if you go for motorcycles. So then we could probably make some of the severe injuries or turn them into moderate or even into minor injuries. So actually, what we see is that there is a need to increase the use of protective equipment, and to promote that, we probably need something that is as cool as Hermann Mayer's helmet. You know, what happened when, well, you saw him on screen every day in winter, and the result is that today more or less everybody wears a helmet for skiing. So probably we should take this as an example and find something that is as cool as Hermann Mayer helmets. As for me, it is the jacket you can see on the right side. So this is more or less a mesh jacket. Looks quite nice, but has all the protective equipment inside, and it's quite nice. And you also could use airbags, as you saw. The urban riders are hardly protected, but the upper body is a problem. So probably we can at least make them wear airbag jackets. What we need to do, we heard a lot about underreporting today. Consider the target crashes if you try to find out and evaluate the use of protective equipment. And something that has not been mentioned today, if we use all these protective measures, we need to consider the potential for risk compensation. So in general, it is also, this is my recommendation. I think it's necessary to make safety ratings for personal equipment, protective equipment, more accessible, make them easier to do that on a general level. So make it more accessible, easier to see what is good and what is not that good.
Brilliant. Thank you very much. Thanks, Martin, for your excellent presentation. So yeah, there's the challenge. We need to find something as cool as Hermann Mayer's helmets. But no, it was a great presentation on the importance of protective equipment and where to focus for powered two-wheelers. So our next speaker is Astrid Lindner, professor on transport safety at the VTI from Sweden. One of our leading experts worldwide. So this is also very relevant when we're looking at seriously injured people in the EU, because we've got a significant gender difference. So 66% of those seriously injured are male, but studies show that men and women are not equally well protected, both inside and outside the vehicles in the event of a collision. And there are variations as well in the different countries. Astrid, over to you. I'm going to present the differences in male and female risk.
Thank you very much. And my apologies for not having the camera on, because I'm in an area where I have very low internet connection capacity. So I will focus on showing you the presentation. So I will start with that and see if I can get this one to work and get it in presentation mode. No? You don't see it in presentation mode?
Not yet. Not yet.
I try it again.
Thank you. Yes, perfect.
Does it work?
Go ahead. Yeah, thanks, Astrid.
Excellent. Then I don't touch anything then. Okay, thank you for the introduction. And as you have already presented who I am, I will skip this one because I had, but it shows that I have a long history in this area, and also that I'm addressing this from an engineering perspective. So when it comes to countermeasures, but you will get some examples of that later on. So I am focusing in this presentation on the part of what we call we have another name for it in Sweden is severe injuries, which also include disabilities. And disabilities are here. This is the PMI, permanent medical impairment, 10% and more. So this injuries that affects your everyday life. We have PMI on 1% and more, which are less severe, but still permanent disabilities. But the severe ones, we use the category 10% and more. So here you see the distribution in Sweden when it comes to these severe impairments. And you can see that we have a similar number of car occupants and cyclists, which was highlighted before, that we have this big challenge when it comes to cyclists. When you look at these data on PMI 1% plus, then you will see that you have majority of the cyclists. So it's important here to ask when you get figures what type of PMI, for example, it is. Otherwise, you can easily get confused and think that, oh, is it very different in different regions and so on? But it is also depends on the type of severity you're looking at. So now.
Okay. All right. So I think then we should go to the last speaker, and if we manage to reconnect with Astrid, she did say that she was tuning in from being out and about. So if I could introduce then Masha Ojic, junior researcher at SWOV. So as we've heard, cyclists are a big focus. They represent the highest proportion of those seriously injured in Europe, representing 25% of all seriously injured. Masha, who I hope is there, oh, super, great. Will present how the Netherlands has tried to make Dutch roads safer for cyclists by changing infrastructures. Thanks for jumping in here. The floor is yours, Masha. And actually, could I also just say questions are still very welcome for our last round of speakers. Over to you, Masha. Thank you.
Yes, thank you. So my name is Masha Odijk. It was a good effort on my last name, but it's very Dutch, so it's a bit complicated. I'll tell you something about infrastructure changes to reduce single bicycle crashes and what we do here in the Netherlands on behalf of SWOV. So I split the presentation into 3 parts. First, I'll tell a bit about single bicycle crashes in the Netherlands, then the role of infrastructure, and then I'll go into the actual measures that we can take to reduce these type of crashes. So in the Netherlands, so on single bicycle crashes, so this is a crash where no other road users are involved, and it often entails a fall or a crash against an object of a cyclist. And in the Netherlands, 36% of bicycle fatalities are from these single bicycle crashes. And for some context, about half of the bicycle fatalities are from crashes with motor vehicles. When we look at the age differences, so here you can see a graph that distinguishes between elderly and non-elderly. We see that elderly are more often involved or more often fall fatal in single bicycle crashes than the younger population does. And then if we look more specifically into seriously injured cyclists, you see here a graph that goes from nowadays back until 30 years. And you can see very clearly that in the last 15 years, we had a very strong increase in seriously injured cyclists here in the Netherlands. And that increase is mostly in crashes that do not involve motor vehicles. So the dark green are crashes with motor vehicles and the light green are crashes without any motor vehicle involved. So that's either a single bicycle crash, but also crashes with pedestrians and cyclists. And these days, 80% of all seriously injured crashes are without involvement of a motor vehicle. And a large part of that are then single bicycle crashes. And this really shows how important it is that we look further into these single bicycle crashes and that we try to do something about it through infrastructural measures. Which brings me to my next part. To prevent these crashes, we need to know how they are caused and which infrastructural elements play a role in the crashes. What we first need to know is that crashes are caused by a complex combination of circumstances. So it's often not one cause, but many things that come together. It can also be that there are multiple infrastructural elements together that result in a single bicycle crash. A Dutch study on single bicycle crashes looked into specifically the role of infrastructural elements that caused the crash or that had an influence on the outcome of the crash. And in this study, it was found that 50% of single bicycle crashes here in the Netherlands had some cause, that the infrastructure had some cause in this crash. And here you can see in this graph which type of infrastructural elements then played a role in the crash occurrence or the outcome. So for example, slippery roads had quite a big impact, but also the curbs, run-of-the-road crashes, and where the roadside was somehow an issue, but also bollards and road narrowings, which caused crashes for cyclists. So these are objects for cyclists can crash against. Bumps and potholes, so unevenness in the pavement is also an issue. Vehicle doors and parked vehicles, vehicle doors, for example, that open and a cyclist cycles against it. And also a small part of the crashes was caused by roadworks on or alongside the road. There is some overlap between the categories. 8% of the crashes in the study had multiple infrastructural causes. So there were more than one infrastructural element that caused the crash. And then if we would like to know what actually we can do to prevent or to at least reduce the single bicycle crashes, we can take measures for this, but we should know that even when all infrastructure is safely designed and well maintained, not all single bicycle crashes can be prevented. But a Dutch study did look into, okay, what if we do ensure safe infrastructure and we maintain this well? What can be the effects on these crashes occurring? And this study found that 50% of the crashes as a result of run-of-the-road events and 50% of crashes due to slippery roads and longitudinal grooves can be reduced if we design properly. Crashes caused by bumps and potholes and objects on the road can be reduced even further by 75%. And the study also found that we can fully prevent crashes with bollards and road narrowings, which is a very positive finding. And then, of course, the question is, what do we do? So I'll go into each type of single bicycle crash and then explain a bit about what we can do to prevent these crashes from happening in the infrastructure. So first, when cyclists lose their balance due to bumps and potholes, it's recommended to apply a closed pavement rather than open pavement because it's often a lot smoother. But then it's also important to consider proper greenery and tree types to prevent the tree roots from breaking up the pavement. And then we have crashes against the curb, which can also be largely prevented. It's not always necessary to apply curbs, so it should be considered carefully if it's actually necessary. It's recommended to remove them on narrow roads because there it's more likely that cyclists will cycle against the curb and then fall. It can also be chosen to apply lower curbs or have them a bit more sloped. That will also reduce the probability that a cyclist will hit the curb. And then you can also choose to have them stand out more, for example, by giving them a bit of paint so that they're more visible for the cyclists and that they know that there's a curb there. Then we have the run-of-the-road crashes and cyclists falling on the roadside. Here we can prevent this in twofold. So there are two ways. First, you want to try to keep the cyclist on the road, and you can do this by applying edge lines so that it's more clear for them where the road ends. And secondly, you also want to allow the cyclist time and space to correct themselves and also make the roadside safer. For example, by avoiding height differences and obstacles on the roadside, which gives them either the space to fall safely or to move back onto the road. And then we have the crashes into bollards and road narrowings, of which I said we can fully prevent these crashes. It's recommended to really only use bollards when strictly necessary. So an example of this is, for example, a bicycle bridge where you really don't want cars driving on it because it's not strong enough or it's not calculated for that kind of weight. Then it's logical to put a bollard there, but in other cases it's recommended not to do this. And also in the Netherlands, a lot of these bollards have been removed to prevent these crashes. And then for traffic calming measures, it's recommended to apply measures without obstacles. So not the road narrowings, with sometimes also combined with bollards. That is not recommended to do that. So if I take it all together, the infrastructure measures to prevent single bicycle crashes, the first is no obstacles, not on the road or nearby the road to prevent cyclists from crashing into those. Then a visual guidance to help cyclists stay on the road. Also important is to provide smooth pavement to prevent cyclists from losing balance and falling. And lastly is the forgiving roadside, where you give cyclists time and space to correct their mistakes. And that was my presentation.
Super, thank you very much, Masha. I was just thinking about my own bike ride this morning coming into the office, which had a lot of those challenges that you noted there, including going onto the pavement to go around roadworks. Right, so we're going to try to reconnect with Astrid. Masha, we have two good questions for you, so please will stay with us. Hopefully this works. Maria is going to go through the presentation, and Astrid is going to join just with audio only. So let's go. Maybe if we can go forward. Maria, we've done this one, slide one. Next one, please. Yeah,
and do next one, and next one. Yeah.
Brilliant.
Can you hear me?
You and Astrid and Maria,
Yeah,
thank you very much. And
excellent.
if we could try, I will give you like seven more minutes, so we have the 5 for the questions. Okay, so 7 minutes starting now. Thanks, Astrid.
I will be faster. Yeah, thank you for giving me this opportunity. I wanted to highlight here. So we looked at we are looking at into permanent medical impairment. So it's disabling injuries, and so we are looking even further here to car occupants. What are which body regions? What are the injuries that give us these long-term consequences? And as you can see here on the plot, it's from insurance data. So hospital data, police data is not enough here to get us this resolution. Then we these data, even if they are from the Strada, it's also based on what the insurance knows. So insurance company. And here you see then that injuries to the spine, cervical spine, are totally dominating, and this is what we are often referred to as whiplash injuries, soft tissue injuries caused to the neck that can give us these disabling injuries. Of course, then second you have head injuries, as we have talked about before, and then comes the rest. Next, please. So I dig into the data from Folksam, which is the largest, one of the largest insurance company in Sweden, and they had looked at development of the cars in crashes from 1980s. Often we talk about that safety has improved, and it has. Yes, we will look into that. But when looking at females and males and their risk of injuries, we still have a big challenge. So next slide, please. So these are crashes that occurred in 2000 to 2019. There are two vehicle crashes, over 100,000 of them. We have nearly 150,000 diagnosed injuries for 55 plus occupants. And cars here were categorized into 10 years period because, as we know, safety improve and so on. So to see how that develops. And then, as I said before, that we have the injuries leading to permanent medical impairment, which takes up to 3 years to be established by the insurance company. It's done by medical expertise long after the crash, of course. So next slide, please. So here you can see the risk for relative injury risk for males and females divided into males and females. So you have at the top, you have any injuries, you have serious and fatal injuries, fatalities, and then permanent medical impairment. And there's a lot of data here. This is a publication. You can look at the details. But I want to highlight that even if we have had this really positive reduction, we still have a similar difference between males and females in that females are less well protected in the event of a crash. Next, please. So here now we are at a permanent medical impairment of 1% and more. And here again is showing you the same picture that we saw before, that for these injuries, so the injuries to the neck, which is then whiplash injuries, still fully dominate. And this is something that we can address. So that's the good news here. So please, next picture. So looking more into whiplash injuries, what is this? Where do they occur? Well, yeah, they occur, or first of all, they, as you saw, are the majority of the injuries that leads to permanent medical impairment for the insurance company. They are most common, as you see in this pie shot, in rear impact, but they also exist in frontal and side impact. The risk of having these consequences if you have initial symptoms is the same in all impact directions. But the number of low severity crashes are higher when it comes to rear impacts. That's why they dominate. And the hypothesis is about what is causing the injury is injuries to the soft part of this of the cervical spine early on in the event, which is called a retraction motion. That is what you see here in the picture. Next, please. Some historical data from 1969 onwards. This is risk of injury, whiplash injuries, males and females separated in the studies that has been published, and there are more even after 2009. The risk for males are set to 1, and then you have the risk for females in comparison. So you can see here that females have, in all these studies, which are in terms of science, scientific studies, it's quite rare that you have this the same trend for all studies. But that's the case here. So we have known for a long time, and we know well that females are less well protected when it comes to these injuries. Next, please. So what can we do? In a low severity or in a rear impact and in a low severity rear impact, it is the seat that has the absolutely largest potential to protect us. And here again we have data from insurance company. This is from Folksam again. They have looked at different type of seats and the risk of permanent medical impairment at the level of 10% more and more. You have 3 bars, standard seat, bar with different types of seats which has something called a reactive head restraint, and then a bar showing the wheel and the whips. This was in 2013, so give you the time history here. And what you see is that when we look at the data this way, then we rightly draw the conclusion that we have had an improvement in protection from both strains and wheel and the whips. Next slide, please. When we divide the data into males and females, however, a different pattern emerge. And I think you can click again to get some more data in this slide, please. See if it works. Yes, here it goes. Come slowly. Oh, no, could you go back, please? So here you have the data, same data, you see that up to the right, for divided into males and females. Standard seat to your most left, reactive head restraint in the middle, and wheel and the whips to the right. And you can see here that for the reactive head restraint, those are the bars in the middle. If any effect, actually, it's negative for the females. So all the protection for performance were for the males. However, both wheel, which is the Toyota system, and whips, which is the Volvo system, they are done in very different ways, but both of those systems shows here to give improved protection. So this is then what we should identify in testing. So next slide, please. So I have estimated, based on Swedish data, when it comes to permanent medical impairment, what it would the numbers for EU. So if you look at Sweden being 10 million inhabitants, we have nearly 500 permanent impaired persons every year, then you see an estimate of what this could be on a European scale. So this is substantial. That is my bottom line here. So next one. Please, next slide.
There we are. We've got a lovely Swedish lake.
But
thank
that
you.
was the end. Thank you for your attention.
Thank you. Thanks very much, Astrid. It worked out. I'm glad we got the technology to work with us. So we have 5 minutes left to squeeze in 3 questions from the audience. Thanks again. So I'd like to ask everyone to come back from the second panel. First one to Veronica. So it's a 2-part question. Should road design standards be harmonized across the EU? Now, Veronica and I and another one of our experts, João Cardoso, have been working together with the expert group on road infrastructure safety. And we have a question linked to that from Vimtal of FEMA saying, should we wait for the expert group on infrastructure safety, EGRIS, to come forward with its own recommendations? So that's the second part of that question. Should road design standards be harmonized across the EU? Or should we wait for EGRIS? Veronica, in a short response, please. Thank you.
Yes, very briefly. The first one, yes, sure we should, because all civil engineering constructions have harmonized standards, so why not roads? And I think that we have a lot of knowledge but different experience, so that would be great to have our specialized community to work together to prepare the unified standard with some national appendix like in other standards. And for the second one, I think it's my opinion, but I think it's not necessary, because most of the work the consultants for the Commission do is desk research and some questionnaires and looking for the best practice all around Europe. So I don't think that there will be something really new there. In some cases, maybe there will be specified tolerance for example, clear zone, and it can be inspiring. But in many cases, I think that it will be more general than are the national standards.
Okay, great. Thank you very much. So to Masha, as I mentioned, we have two questions. So first one from Matt Steele. In relation to single bicycle crashes, was public street lighting a factor? I mean, some local authorities have been turning off the lights, right? For example, did collisions occur on dark sections of the road? That's the first question. I'm going to add in the second one from Inkari Pakari from Finland. In the Netherlands, do you have data on alcohol in single bicycle collisions?
Yeah, thanks for the question. On the first, on street lighting, the study that I showed that looked into infrastructural elements and causes on single bicycle crashes is already a bit older study, and we haven't been able to renew that study, so I can't really say much about the recent changes in street lighting and how they may impact the occurrence of those crashes. But of course, it's imaginable that it plays a role. Yeah, so that's answer to the first question. And the second question about alcohol, I do not know the exact numbers, but I do know that there is some ideas on the role of alcohol in single bicycle crashes, and then mainly on the number of there's a study that's looked at bicycle crashes as a result of alcohol, and there are some ideas about what percentage of that was caused was a single bicycle crash rather than a crash with other cyclists. And I think also what stands out there is that it's mostly younger cyclists that, of course, also because they drink a bit more alcohol and then are more likely to step on a bike. And as I showed in my presentation, the majority of the single bicycle crashes, the fatal and also the serious injury crashes are amongst elderly. So alcohol, that's not really the question, but looking a bit further, alcohol can play a part in the single bicycle crashes, but I think the biggest issue is that it also occurs so much amongst elderly, and when they fall, the injury is much more severe. So that's also really something we should focus on.
Super. Thank you very much. Astrid, if you're still there, you mentioned two systems, so Will from Toyota and Whips from Volvo, that perform better than standard seats. What about the other manufacturers? Do they use standard seats?
Yeah.
Do we need mandatory measures or voluntary measures, for example, Euro NCAP?
I think, first of all, we should identify the best innovations. And it's an excellent question, because it's really highlights that we don't have the resolution in our testing today. And as these assessments develop, in especially when it comes to identifying the best performing measures, then it is consumer information. But also in regulatory tests, we don't have any dynamic test for low severity and or low severity rear impacts. And so I think it's a matter of doing both, but to identify the best innovations, that would be done in consumer testing initially.
Super, thank you very much. I'm afraid that's all we have time for today. Thanks again to all our speakers. Brilliant presentations. And also, of course, thank you to the ETSC team, especially Jenny and Maria, for putting together this event. Do take a look at our PIN report on serious injuries. Thank you to all of you participants for coming, for sending in questions as well. We very much hope it was useful. And in terms of what's coming next, our next PIN flash will be on work-related road safety, and that's going to be published still this month, November. All right, have a good rest of the day. All the best. Thank you. Bye-bye.